Hi everybody, let's discuss some important points regarding humerus. Humerus is the long bone in the arm. Okay, what is the first point? We have what is the anatomical neck. Anatomical neck, okay, this is the humerus, this is the shaft of the humerus, this is the upper end of the humerus. In the upper hand we have head. The line separating the head from the rest of the upper end is the anatomical neck. So what is anatomical neck? The line separating the head from the rest of the upper end. Okay, then surgical neck. What is surgical neck? The narrow line separating the upper end from the shaft, that is the surgical neck. Then morphological neck. It lies about 0.5 centimeters below the surgical neck and it is the position of the epiphyseal line. So you know three lines, three necks. There is anatomical neck which is between the head and rest of the upper end, surgical neck between the upper end and the shaft, and 0.5 centimeters below it is the morphological neck. It is the place where epiphyseal line is located. Then coming to lower end. In the lower end we have capitulum and trochlea. Okay, in the lower end we have capitulum and trochlea. Coming to capitulum, remember capitulum is on the lateral side towards the radius. Trochlea is on the medial side, that is towards the ulna. Okay, capitulum, it normally articulates with the head of the radius. And the trochlea, it articulates with the trochlear notch of the ulna. One of the important point about the trochlea is it has lateral edge and medial edge. So coming to the medial edge, it is 6 mm more than the lateral edge. Why it is 6 mm more than the lateral edge? To form the carrying angle. Okay. Then we'll see about the fossa. Three fossa. This is the anterior aspect of the humerus. We have coronoid fossa medially and radial fossa laterally. Okay, what happens when the elbow gets flexed? When the elbow gets flexed, this coronoid fossa, it accommodates the coronoid process of the ulna when the elbow is flexed, and the radial fossa, it accommodates the head of the radius when the elbow is flexed. Coming to the olecranon fossa. It's located posteriorly. It accommodates the olecranon process of ulna when the elbow is extended. Okay. Then muscle attachments, which are very important. Coming to the muscle attachments, this is the lesser tubercle, this is the anterior aspect of the humerus, and this is the lesser tubercle, this is the greater tubercle. And in the greater tubercle, it has again three impressions: upper, middle and lower. So now coming to the what are the attachments. Coming to the lesser tubercle. Lesser tubercle, the muscle which gets inserted to the lesser tubercle is subscapularis. Remember, subscapularis. And greater tubercle. Three muscles get inserted on the greater tubercle on the three impressions. So on the uppermost impression we have supraspinatus, and the middle impression we have infraspinatus, and the lower impression we have teres minor. These are very important. Just remember kids, uppermost part supraspinatus, middle infraspinatus, lowermost part teres minor. The muscle gets inserted. Insertion is different, origin is different. The muscle get inserted. Okay. Then coming to the intertubercular sulcus. This is the intertubercular sulcus. It has a lateral lip and medial lip, and it has a floor. So what are the muscles attached? To the medial lip? To the medial lip we have teres major muscle is attached. To the lateral lip, pectoralis major muscle is attached. And within the floor we have latissimus dorsi. So how do we remember? It is a lady between two major. So on the lateral lip we have pectoralis major. On the medial lip we have teres major. On the floor we have latissimus dorsi. One more thing you have to remember, what are the contents within the intertubercular sulcus. One is the tendon of the long head of biceps brachii and its synovial sheath, and ascending branch of anterior circumflex humeral artery. So the deltoid we have deltoid tuberosity, we have deltoid muscle which is attached. Next, coming to the other muscles. Coming to the supracondylar ridge. So this is the lateral epicondyle. The above one is the lateral supracondylar ridge, medial supracondylar ridge. So what are the muscles attached to the lateral supracondylar ridge? Okay. So lateral supracondylar ridge, we have upper 2/3 and the lower 1/3. So brachioradialis muscle, it arises from the upper two-thirds. It arises from the upper two-thirds of the lateral supracondylar ridge. And in the from the lower one-third we have extensor carpi radialis longus muscle, which arises from the lower one-third of the lateral supracondylar ridge. Then we have medial supracondylar ridge. In the lower one-third we have a muscle which arises, pronator teres muscle arises. So next is the most important question which will be asked in your viva, kids. So we have an medial epicondyle, lateral epicondyle. From the medial epicondyle, it is a common flexor origin. It is a common flexor origin. So common flexor origin, okay. Here the superficial flexor muscles of forearms arises from the medial epicondyle. Remember, kids. Then we have lateral epicondyle, common extensor origin. Here superficial extensor muscles of the forearm and supinator muscle arises from the common extensor origin. Then from the posterior surface we have another muscle which arises, that is of the lateral epicondyle posterior surface we have anconeus muscle which arises. Okay. Now coming to the nerves related to the humerus. There are different nerves which are related to the humerus. We have which are liable to injury. Okay, one is the axillary nerve which arises at the surgical neck. Near the surgical neck we have axillary nerve. Near the radial groove we have radial nerve, and behind the medial epicondyle we have ulnar nerve. So at the surgical neck we have axillary nerve. At the radial groove we have radial nerve, and behind the medial epicondyle we have ulnar nerve. These are the nerves which are liable to injury. Okay. So coming to supracondylar fracture. Okay, supracondylar fracture occurs somewhere here. Okay, what happens when the supracondylar fracture occurs? It may cause injury to the median nerve, and it also causes occlusion of the brachial artery leading to Olkmann's ischemic contraction. Remember, supracondylar fracture leads to injury to the median nerve. Then humerus has a poor blood supply at the junction of upper one-third and lower two-thirds. Okay, upper one-third and lower two-thirds. So when the fracture occurs here, there are more chances of delayed union and non-union. Okay, thank you.